Michael, Maddie. Thank you for joining us before your first shift here on the floor in labor delivery. I'm Lori, this is Michael, we're labor and delivery nurses, and we're here to talk to you today about postpartum hemorrhage, so you're ready and prepared to deal with it when it happens. Okay. So we got a few learning objectives that we're gonna work on today, and this may not make sense until we go through them, but at the end of this, you're gonna be able to tell us at least 2 signs and symptoms of postpartum hemorrhage.
Okay.
You're going to be able to demonstrate how to correctly massage the fundus, which is the uterus of the pregnant woman, as prevention and treatment for postpartum hemorrhage. Michael is going to show you how to use an intrauterine balloon device like a Bakri, and you'll be able to communicate back what that does. And then we're going to show you how to calculate blood loss in a postpartum patient, and you're going to demonstrate that you know how to do that. And lastly, Michael's going to go over some pharmacological measures for postpartum hemorrhage, and you guys will be able to explain 2 of those and when and how we would use them. Okay?
Yep.
The first thing that we need to talk about is that postpartum hemorrhage is pretty common. So our role in this is making sure that we're able to assess for this early. Prevention is key in postpartum hemorrhage. So the sooner we notice it, the sooner we treat it, the better outcome for the mother.
Okay.
So the normal uterine blood flow rate, it's 60 milliliters per minute, but when you're pregnant, it goes up to 600 milliliters per minute. So there's a big increase there. And so postpartum hemostasis, or getting the blood flow to stop after a baby is born, is really reliant on uterine contractions. And also the activation of the coagulation cascade that we've learned about in nursing school up to this point, right?
Okay.
So there are 4 main reasons for postpartum hemorrhage, okay? The first is tone. Just remember the 4 T's. The first is tone. So when we're talking about tone, we're talking about the uterine contractions. So uterine atony, or the lack of contraction in the uterus, is the #1 reason for postpartum hemorrhage. That accounts for about 70% of postpartum hemorrhages. Trauma is the second one. That is like lacerations or rupture of the uterus during the birthing process. That's about 20% of postpartum hemorrhages. Tissue is like retained placental fragments, so the placenta doesn't come out in full after delivery, and things like that can lead to postpartum hemorrhage as well, about 10% of them. And then the last one is thrombin. So that's like coagulopathies. So if somebody has a bleeding disorder, that puts them at a higher risk for postpartum hemorrhage, but that's rare, that's less than 1%. Do you have any questions so far?
I don't think so.
Okay. So now, signs and symptoms of postpartum hemorrhage. The #1 sign and symptom of postpartum hemorrhage is bleeding. We need to recognize what's normal bleeding versus abnormal bleeding, right? Because the other symptoms that might show up, they can be later symptoms. You may not see that until there's been a lot of blood loss already. But those things can include things like hypotension, your blood pressure is going to drop as you lose blood volume, tachycardia, that's your body's response to try to keep up cardiac output, things like shortness of breath, you might have tachypnea, you may notice that there's not a lot of urinary output, cyanosis, dizziness, dry mouth, things of that nature, okay?
So we're really just looking, like the major signs is low blood pressure and just bleeding.
And bleeding,
Okay.
yeah. So those are the 2 big ones that you're gonna look for, so that's great that you picked that out, okay?
Do they have clots with their bleeding?
Yeah, they will have clots, and you may see some very large clots, so that's an indication of postpartum hemorrhage as well, is you're gonna see those abnormally large clots. Great question. Okay, so now we're gonna talk about prevention, assessment, and staging and interventions for postpartum hemorrhage, okay? So we need to do an adequate risk assessment when every mother comes in. And then we need to start thinking about preventative measures, because if we can prevent it all together, we're gonna have better outcomes for our patients, right? And so there's things called postpartum hemorrhage care bundles, and there's 4 that we really focus on. Readiness is the first one, and that's things like a hemorrhage cart. Have you ever seen a hemorrhage cart?
I'm not. Do we have one?
We do have one. The second is recognition and prevention. So that's immediate access to the hemorrhage medications and tools that we need. That's things that Michael's gonna go over here in just a little bit.
Okay.
The third is response. It's knowing how to respond and how to up your response based on the severity of the hemorrhage. And the last one is reporting in systems. And so that includes things like unit education, what we're doing here today, because the educated nurse is going to be more effective. And then drills, we're gonna practice our skills, not wait until an actual patient presents with these. Okay, so now we're gonna talk about pre-screen for risk. Again, we need to make sure that we're preventing this as much as we can. And so if a patient is at risk for postpartum hemorrhage upon admission, there are some things that we're going to do right off the bat. We're not going to wait. And those are things like placing 2 large bore IVs, going ahead with continuous oxygen and cardiac monitoring, and then some baseline labs. We want to know what their current CBC looks like and also what their current coagulation looks like. We're going to go ahead, blood type, and cross match them. Maybe have some blood on standby once we know their blood type. And if they're very high risk, we're going to go ahead and place a central venous access device and an arterial line. That's going to prepare us should we have to do some more measures if they do start hemorrhaging.
Okay.
So what puts a woman at risk for postpartum hemorrhage? It's going to be things like, did she hemorrhage in a previous delivery? Has she had any uterine surgery, even not related to childbirth? Is she a multiple gestation, twins, triplets, higher number multiples? Obesity puts you at a higher risk. Things like placenta accreta, that's when the placenta is embedded in your uterus too deep and may not detach properly, or like we talked about before, a known coagulopathy. Okay? All right.
Now with the labs, would you focus on looking at hemoglobin and hematocrit?
Yeah, hemoglobin, hematocrit, you're gonna look at red blood cells and platelets as well. Those are the things that we're gonna focus on to determine whether or not we have some underlying bleeding disorders or if their baselines are already below normal, okay? So other preventative measures we're gonna do regardless of whether they're hemorrhaging currently or not. Anything less than 1,000 milliliters of blood loss is considered not hemorrhage. It used to be 500, they've upped it to 1,000 current standards. So for every woman that comes in here and gives birth, regardless of route, we're gonna go ahead and give them oxytocin after delivery. That's gonna stimulate muscle contraction to make sure that we're trying to prevent hemorrhage. We're gonna do a firm fundal massage, and we'll talk about that in just a minute, but we're gonna do that for 15 plus seconds until we feel that the fundus is firm. We're gonna make sure that we're inspecting the placenta after delivery, make sure it's intact. If it's not intact, perhaps we have retained fragments that we need to look at.
Okay.
Before the healthcare provider leaves the room, we need to make sure there's no lower genital tract lacerations that need to be repaired.
Okay.
Okay, and we're gonna calculate blood loss, which we're gonna go over that in just a minute as well. And for high risk patients, we're going to give TXA, which Michael will talk about in just a minute, okay? So again, every birth, every time, prevention is key, okay? All right, so now why don't we go ahead and head over to our sim mom, and we'll show you how to do a fundal massage.
So now we're gonna do a fundal massage. So you're gonna get the bottom, hold the bottom of the uterus, get the fundus at the top of the uterus, and you're gonna feel it, okay? You just wanna kind of massage it right there. Would you like to demonstrate?
Sure. Hand at the bottom, press the uterus up, find the fundus, and massage.
Beautiful.
Okay, so now we're gonna talk about calculating blood loss. So we've gone through all the preventative measures. Now postpartum hemorrhage is occurring. What do we do about it? First, we need to stage postpartum hemorrhage. We need to figure out how bad the problem actually is. And that's why we calculate blood loss.
Okay.
So the number one thing to remember is that visual estimation of blood loss is not accurate. We need to have a quantifiable number so that we can accurately determine how bad the hemorrhage is. And so what we're gonna do is weigh all blood soaked items. Exchange rate, if you will, is 1 gram to 1 milliliter.
Okay.
So for every 1 gram that you weigh, that's equivalent to 1 milliliter of blood. Okay. So I do have a list here for you of average dry weights of common items that you're going to see. Okay. So you're going to take all of these items. You know what the dry weight is. You're going to weigh the blood-soaked item, and you're going to subtract the dry weight.
Okay.
You're also going to take into account clots. So if there's large clots coming out, it's more of a solid matter. You're going to put those in a container. You're going to weigh that container, subtract the weight of the container, and add those clots to the total blood loss.
Okay.
Okay. So for example, on these dry weights items, let's say that we had a 4x4, and I'm just giving this to you because it's one to easily wrap your brain around. A 4x4 weighs 3 grams dry.
Okay.
Okay. So let's say that we have a 4x4 that's completely saturated in blood. You take this 4x4 and you put it on a scale, right? And it weighs 10 grams. How much blood loss are we measuring right there on that 4x4?
So 10 grams, that'll equal 10 mLs, but you have to keep in mind the dry weight, so -3, so 7 mLs,
Right.
7 grams?
Yeah,
Okay.
absolutely. So you're just going to keep weighing the blood soaked items as they come out. You're going to keep an accurate tally of them, and it's all about documentation to make sure that we are accurately measuring how much blood loss is occurring.
Okay.
Okay? So we've said postpartum hemorrhage is occurring. So we're measuring blood loss. We're going to make sure that we're assessing vital signs regularly. Again, we're looking for hypotension, tachycardia, shortness of breath, perhaps a low SpO2. We're going to figure out, why are we hemorrhaging? Is it atony? Is it retained placenta? Remember your 4 T's. We're going to calculate the blood loss, determine the total volume. We're going to stage the severity of the hemorrhage based on the total blood loss, and then from there we have protocol based on the stage of hemorrhage. Okay? So going through stages, stage 1 hemorrhage is anything greater than 1,000 milliliters of blood loss or signs and symptoms of hypovolemia. And those are the things like the hypotension, the tachycardia.
Okay.
There is a list here of interventions that we would do for stage 1 hemorrhage. This is all in our policies and procedures manual, so we have this readily available at the nurse's station.
Okay.
I would recommend that you familiarize yourself with this, but the interventions are vital signs, calculating blood loss every 15 minutes, and then making sure that we're identifying the source and trying to fix it. And so that includes exposing the perineum, making sure there's not lacerations and things. Okay, so you saw fundal massage, but bimanual fundal massage is something you're going to see the healthcare provider do. It is not something that you're going to do. And so when we have a stage 1 hemorrhage, they're basically going to perform the same maneuver, but rather than placing the hand at the pelvis, they're actually going to put their hand inside of the woman's vagina and massage it internally. And so that's going to help stimulate greater uterine contractions, okay? So stage 2 hemorrhage is anything between 1,500 and 3,000 mLs of blood loss, okay? So all of the interventions that we're doing with stage 1, but we're basically stepping it up. We're going to place a CVAD, we're going to run some labs, we're going to try to figure out what's going on, and from our baseline of labs that we ran previously, we're going to see, are we experiencing, you know, lower platelets, is there a coagulopathy going on, and we're going to increase the frequency of our vital signs and our quantifying blood loss, okay? And so with that, in stage 2, we start working on things like intrauterine devices, and so Michael's going to tell you all about that.
Okay. And right here you can see the different amounts of blood loss. We're looking right there. So that gives you like a picture of it. Okay. And then, so I'm gonna show you the Bakri balloon. So here is like my little example of a Bakri system. So we have the 50 milliliter syringe I was saying earlier. This is your Bakri. We need some tubing, and you need your like normal saline. So this is an example of a uterus, and this is like all the blood inside. Okay. So you go through the vaginal opening and into the uterus, and you just insert it all the way like that. And then you would want to pull back. So we use the stopcocks here. You pull back, I already did. So now I'm just going to turn the stopcock that way, and we have this one pointing that way to the balloon. Just kind of inflate the balloon. You see how it's inflating there?
Mm-hmm.
Oh, wow.
Okay.
And that's putting pressure on the uterus to stop the bleeding?
Yep. So then we pull some more fluid back. Because this is 50 milliliters, you want to usually do like 300 at least. Because if not, the balloon's just going to fall out.
Okay.
So going to be between 300 and 500 per the healthcare provider. Okay. Do it again. So right now I have 100 mLs in there. We just keep going. And this would be done sterilely too, by the way.
Okay.
So essentially that's how it's done. You'd keep going until about 300 and it expands fully.
Now we're on to stage 3 hemorrhage. Stage 3 hemorrhage is 3,000 milliliters plus a blood loss or suspicion of DIC, which is disseminated intravascular coagulation. I'm sure you learned about that in school.
Mm-hmm.
This is where we pull out all the stops. We're doing full blood transfusions. We're going to continue to run labs. We're going to do vital signs and calculate blood loss every 5 minutes. So now we're going to move on to pharmacotherapy.
So some medicines that we give, there's 4 that I'm gonna go over. So the first one is Pitocin, you have Cytotec, you have Metrogen, you also have Hemorrhage, and they're all given different routes, but just give it as the order is written, okay? There's also TXA, which that's for like if you have severe blood loss for blood clotting to help with that. Since I went over the medications, can y'all give me a medication each and what it's used for?
I will be giving oxytocin to stimulate uterine contractions.
Okay. I'll be giving TXA to help with the blood clotting.
Okay.
And we'll be giving those as directed by the order.
Correct. All right, so some contraindications for Metrogen, for hypertension, you don't want to give it, or like preeclampsia. Then Hemorrhage, you don't want to give it if they have a history of asthma or like cardiac disorders as well.
Okay.
Here's our learning objectives. We talked about them in the beginning. Do you guys feel like we've met all of these objectives with the teach backs and the verbalization?
I think so, yes.
Okay, great.
This session has definitely helped me understand postpartum hemorrhage better.